Thank you very much, Chris, and thank you for your invitation to be part of today's event. And thank you too to the participants who've joined in, and look forward to your questions later on. I'm going to stick to a text because otherwise I'll wander off content and time. So forgive me if it sounds a little bit robotic at this end. I hope to share some slides with you as we go along to illustrate some of the points I'm making. There's little doubt that the pandemic and its impact upon individuals, communities, and the nation represents a generational event. And indeed, it's just 100 years since the Spanish flu, which is the closest example we have in barely living memory. We can reasonably expect that the stresses and experiences created by the pandemic pose a mental health and well-being risk to individuals. And there's already been much discussion in the various media about the impact, ranging from the traumatic experiences of patients in ICU and the staff who are caring for them, through to those experiencing some anxiety regarding future employment, income, and the affordability of their current lifestyles. There's no doubt that the immediate future is uncertain for many people, and it's not easy living with uncertainty. Over the next 30 minutes or so, I want to talk about some of the things we learned from our work in Northern Ireland responding to the impact of the Troubles. That's the period of political violence that went on from the late 1960s until the present. Clearly, the circumstances and the context are very different, but there is one common endeavour, and that is, how do we go about trying to understand what the impact of a stressor on the community is? And what does that then tell us about what we need to do to discuss the needs that we've identified? The Omagh bombing occurred on the 15th of August 1998. 31 people were killed and over 400 were injured, of whom 135 very seriously. Hundreds of people were exposed to traumatic experiences at the scene, the hospital and other locations after the explosion, and the impact rippled across the wider community and indeed beyond to Donegal and to Madrid. It was by many metrics the largest single atrocity associated with the most recent period of political violence in Ireland. Ironically, as you may recall, it came just 4 months after the political parties and governments had reached what we now call the Belfast or Good Friday Agreement. As Chris has said, at the time of the bombing, I was the Director of Community Care with the local Health and Social Care Trust. This provided a whole range of hospital and community services and social services to Omagh and the wider district. In the years that followed, I coordinated the community services response to the bombing. One of the first things we did was to set up a trauma centre, which we called the Omagh Community Trauma and Recovery Team. This team remained in place for 2.5 years after the bombing and received 670 referrals during that time. Thereafter, we established the Northern Ireland Centre for Trauma and Transformation, which for 10 years up until 2011 went on to further develop the trauma-focused therapeutic services that had been put in place by the original Omagh team. This new centre also went on to undertake a series of major epidemiological studies of the impact of the Troubles on mental health and well-being in Northern Ireland, in partnership with Ulster University. We also developed a suite of trauma-focused, skills-based accredited training programs. After the centre closed in 2011, I began writing the book. And as Chris has said, it was published by Manchester University Press in 2017. In the book, I attempted to synthesize what we learned from the work I've just outlined and to undertake an extensive review of research from the late 1960s into the psychological and mental health impacts of the Troubles. It is from this work and the discipline of writing the book I want to share some thoughts as we turn our attention to the long-term consequences for well-being in the wake of the COVID-19 pandemic. Writing in 1919, W.B. Yeats reflected on the world in the wake of World War I, and just as the Spanish flu was unfolding into a world of turmoil. In his poem, The Second Coming, he wrote of uncertainty of what lay ahead in the future. And in those memorable lines, he said, "Turning and turning in the widening gyre, the falcon cannot hear the falconer. Things fall apart, the centre cannot hold. Mere anarchy is loosed upon the world. The blood-dimmed tide is loosed, and everywhere the ceremony of innocence is drowned." As I noted a moment ago, living with uncertainty isn't easy, and yet those that have done so or have learned to live with uncertainty often find a new perspective on life. I say this because we want to keep perspective um, in our and a balance in our understanding of what crisis can mean in our lives. Whilst it is often highly destabilizing, a time of crisis can provide the circumstances for thinking again about what is most important in life. So whilst we should properly be concerned about the adverse effects of the virus pandemic and what the effect it could have on individuals, families, neighbourhoods and communities, and indeed nations, we should also recognise that for many it will and can be an opportunity for reappraisal, for reflection, for the rediscovery of things that have been forgotten, or of striking out in new directions. When the bomb exploded in Omagh in 1998, we knew immediately that it would pose a major health risk to the well-being of many people who had been involved and indeed the wider community. But we could not really pin down the scale and nature of what that impact would be. And in fact, 2 days after the bombing, Dr. Bolton, who was then the British Secretary of State, came to Omagh, and in a meeting she had with colleagues and I, she asked us what would the impact be and what do we need to do to address that need. And to some extent, we leaned upon our own experience and our own professional judgment, but in truth, we really could not quantify or describe in any great detail what we thought that impact would be. So, and that initial gut feeling was essential to get things moving. And indeed, it was in those days that we decided to set up the trauma team. In the 12 months following the bombing, we undertook 4 major needs assessments within the local community. These assessed the experiences and needs of adults, adolescents, young children, and the staff of the Health and Social Care Trust. The studies provided invaluable information which went on to shape the development, type and duration of services, and provided the evidence and rationale for policymakers and funders. The studies helped to clarify the objectives of what we were trying to achieve in providing therapeutic services and helped us make judgments on the skill sets that would be required to address those needs. They underpinned the original decision to set up the new service, that is to say, the trauma centre. This experience, coupled with the review of research into the wider impact of the troubles that I referred to a moment ago, demonstrated that it is insufficient to rely solely upon changes in the use of conventional services or changes in the numbers of people being diagnosed with serious mental health disorders to try and understand what the impact of any particular crisis or stress on a community might be. To get an understanding of the impact of such an event on a community, it is hard to better the option of asking populations directly about their needs, and to marry this with knowledge of how services are being used and accessed. I should add here that the evidence from the studies was also highly influential in our conversations with political decision makers. And indeed, it's interesting in the current daily briefings how big a part our scientists are playing in underpinning political decision making. Upon the evidence presented, the politicians were able to support the funding and the delivery of new services for those who'd been affected by the bombing for as long as they were required. When the trauma team got going, we began to track the referrals coming into the team, and this is a graph showing the referrals of 670 referrals or thereabouts over two and a bit years, and you will see the references there to the first and second anniversary. And this is very important, I think, because what this tells us is significant in terms of shaping services. That huge demand of referrals in the first couple of months turned out to be largely acute distress, and it was people seeking help on their own behalf or indeed on behalf of family members, for example, children. And most people got through this period pretty well, supported by therapists and indeed by their family and other services like GPs. If you turn your eye to the right-hand side of the graph where you get a relatively low level of referral, what we see there is people with very marked and complex trauma-related disorders coming through, for which a whole new skill set was required. And albeit this is a single incident, if you think about the COVID-19 being a series of single incidents, then this is the kind of pattern of response that we might expect to find, and also the kind of services that we would expect to put in place in response to each stage. Another key learning point was about proximity and the impact on health and well-being. A very obvious point that the closer you are to traumatic events, then the greater the risks of developing psychological problems. And this indeed was the case, as demonstrated by this chart. People who were in Market Street in Omagh when the bomb exploded had much greater risk of meeting the criteria for post-traumatic stress disorder or the thresholds on the general health questionnaire. That was less so for witnesses, less so but significant nonetheless for people who had been bereaved. And then people who were what we called near misses, who were maybe in the town but otherwise not caught up on the day, and those who were not involved at all. Just on the witness point, I want to make the point that our studies of the healthcare staff, who were involved in responding to the bombing, had mean scores very similar to those who were witnesses on the street in Omagh when the bomb exploded. Another study that we did later with the Ulster University, we asked the question of 3 different groups. This was a secondary analysis of a larger study, and we looked at those who had not experienced any trauma in their life, those who had had only non-conflict related traumas, and then those who had conflict related traumas, or loosely put, traumatic events linked to the Troubles. The yellow chart shows the relative risk of people having no trauma developing any kind of mental health disorder, including anxiety disorders, mood disorders, substance abuse disorders, impulse disorders, and then the total at the right-hand side there. When we asked the same question of people who had only had non-conflict related trauma, you can see the relative risk increases significantly across all categories. And then when we asked the same question of those who had had troubles related traumas, then the risk went up again. So the implications of this, and again, realizing that this is an association rather than a causal relationship here, but nonetheless, I think we can reasonably infer from this that trauma isn't particularly good for your health. And so we should look for people who've had traumatic experience as being at risk of developing mental health disorders, but not inevitably so. I thought I'd put this slide up just to illustrate the point that we also found an association between having PTSD and the risks of having one or other chronic physical health condition. I'll not spend much time on this, but just to make the point that there is this association. Another issue that came up was in both our clinical work and in the studies that were undertaken was the problem of help seeking. And we found that many who had had experiences and had subsequently developed one or other trauma-related disorders had considerable difficulties in contemplating seeking help. There were various reasons for this, and some were linked to the tangible anxieties people had in the context of political violence, where they really thought that their lives were endangered, and indeed they were. From a psychological point of view, the difficulties often related to the existential fears people had about talking about the last thing they wanted to talk about, even in a therapeutic context. It was not uncommon to hear from people that they felt alone in their trauma, that they felt they would fall apart or die if they allowed themselves to think or talk about what they had experienced, or indeed were continuing to experience, or that the therapist couldn't handle what they'd been through, or that they were beyond help. We learned that it was most important to put a lot of effort into assisting people in contemplating seeking help, and then taking the steps that are necessary to do so. Trust and safety were critical ingredients in ensuring that people were able to take those steps. We also found it was necessary to not have referral obstacles in people's way. And so in both the original Omagh team and subsequently in the Northern Ireland Centre for Trauma and Transformation, we had an open referral system where people literally could walk in off the street to access services, and indeed often did. In this next chart, I want to share with you some metadata from the big study that we did with the Ulster University. The blue line represents those who had mood disorders, or what we might call depression. And what this illustrates is that if you look at that 50% line across the middle of the chart, is that 50% of those who met the criteria for mood disorders sought help within the first 12 months after the onset of symptoms. The green line represents those who had addiction or substance abuse disorders. And here we find that roughly half of those who had developed problems sought help within about 15 years. However, if we look at anxiety disorders, and this includes things like panic disorder and PTSD, then the mean time at which people sought help was 22 years afterwards. This is extraordinary that it takes so long for people who suffer so badly to seek help. Indeed, that was borne out in the randomized controlled trial and in other studies that were done, and indeed in the clinical work that was undertaken within both the original trauma team in Omagh and the Northern Ireland Centre for Trauma and Transformation. A parallel consideration is the need to ensure that we provide effective services. In the major epidemiological study that we undertook with Ulster University, we found that only 1/3 of those who met the criteria for trauma-related disorders got access to services which they consider to be helpful. This is a task for practitioners, service providers and managers, funders, training organisations and regulatory bodies. This, of course, also means that we need to provide, from the service user's point of view, services that are accessible, acceptable, usable and effective. And indeed, points towards the necessity of providing a range of services that people can relate to. So in summary, sorry, I just wanted to, this is the outcomes from the randomized controlled trial that we did in Omagh. And essentially what we've got here is a comparison of a waiting list for 12 weeks, which is the yellow chart. You see very low reductions in symptoms on that chart. In the second green line, you see the results after 12 weeks of treatment with trauma-focused CBT. And the main trauma scores come down very markedly and are sustained at follow-up a year later. And this kind of evidence was the first kind of evidence that we had that these kind of interventions could be effective for the highly traumatized population of those who are affected by the Troubles in Northern Ireland. So just to summarize this part of the presentation, most people will be okay after traumatic experiences and loss. There will clearly be a period of adjustment and people will never forget it or get over it in a sense, but they will be okay. They will be able to continue to function reasonably well. There's a risk of trauma-related disorders for those who have had traumatic experiences, as we've covered significantly here. Also the risk of other anxiety disorders and mood disorders. And then drug and alcohol problems, which are often secondary to those primary problems. A lot of people's difficulties go undetected, misunderstood or misdiagnosed by the health system, as we found in our study in Northern Ireland. And then people have difficulty seeking help. I want now to move on to essentially saying a few things about the contribution of non-therapeutic actions in the wake of major stresses on a community. It is clear from observing media coverage of the pandemic and the response to it to date that there's been a lot more to providing a response than solely the delivery of therapeutic and clinical services. It has become clear, for example, that the proper running of society relies upon a whole army of people who deliver vital services for the efficient running of our communities for safety and well-being. And we have heard much about the human and emotional response to the crisis, including expressions of solidarity and the finding of alternative processes of remembrance and acknowledgement, now that the conventional rites of passage have been set aside. In our experience, leadership, both civic and political, were critical ingredients in the response to the Troubles, and at times more than tipped the balance for good when things looked very bleak. In my book, I spend some time in the final chapter trying to articulate what are the necessary and authentic ingredients of leadership in the face of such highly challenging circumstances. In the last few weeks during lockdown, I've gone to the end of our lane on a number of occasions to stand at the roadside in acknowledgement of several neighbours who have died. It was the least and also the most that I could do, given that only close family members are allowed to attend funerals under the current regulations. As I looked down the road, I could see other neighbours standing out to pay their respects. We take the conventional rites of passage so much for granted, and when they are removed from us, we don't quite know what to do. Challenges such as COVID-19 increases this sense of disconnection and further make it difficult to create meaningful but new means of acknowledgement and expression. There is space here for the creator, for the artist, for the pastor, the writer, the poet, and others to articulate and enable what it is, what we feel, what we want to say, to draw our attention to the unknown and invisible things, and to act in support of those who have suffered loss. One such initiative was the Petals of Hope initiative undertaken by an artist, Carol Kane, in Omagh following the bombing. She worked with local people to turn the mountains of floral tributes that had been sent to the town into pieces of art, one of which is illustrated here. One each in memory of those who had died, and also one for each of the 3 towns that were most directly affected by the bombing. Our education system and schools also have a key role to play in assisting children and young people to, on one hand, address the worries and troubles that they are carrying, and to learn new skills that are relevant to the crisis we face. Curriculum initiatives that teach children problem-solving skills, resilience, articulation skills, that draw upon literacy, art, play, drama, music, and other such forms of expression all have their part to play. The inspirational leadership of teachers in Omagh, and indeed earlier after the Enniskillen bombing of 1987, played a major part in supporting young people and their families after they had experienced terrible loss and trauma. At a policy level, it's not sufficient to just provide effective therapeutic services, important though they are. It is essential to also identify and address those conditions and disadvantages that are strongly associated with poor mental health outcomes and other important social determinants of ill health. In a study we did in 2014, we asked community representatives across Northern Ireland to tell us what they considered to be the most pressing concerns of the communities they were serving. At the time, politics and politicians were engrossed in trying to find ways of dealing with the political and judicial legacy of the past, that is, of the thousands of unsolved murders and other injustices that had been experienced during the Troubles. And important though this is, the survey revealed that other matters were of much greater concern to people living in communities, such as poor mental health, drug addiction, poverty, debt, lack of access to opportunity for development, parenting pressures and the absence of parenting skills, conflict within families and such like. These areas also need attention. Before concluding, I also want to reference the evidence that has been emerging in Northern Ireland of the intergenerational effects of loss and trauma, and of the necessity of strategically identifying need, providing services and building resilience and skills as an investment in future generations. And I'll say no more about that at this point. Safe to say that we have been unearthing some of the intergenerational effects. And it fits very much with Martin Knapp's studies in London, for example, the longitudinal studies, that if youngsters don't have positive and developmental experiences from a very early age, then they risk considerable disadvantages in later life. I'm going to conclude in a moment, but just if we, what have I done? Yes, I just wanted to just very quickly talk through this chart, which is really trying to say, what are we trying to do in the aftermath of a major crisis within a community, or indeed in the life of a family or the life of an individual. And our aim clearly is to get people back to something like where they were previously. But obviously we would like to try and even have them experience even greater things. And the idea of post-traumatic growth is a very important idea that we can build upon as one of the goals of our interventions, either at a community level or indeed at an individual therapeutic level. Chris, I'm going to stop there now. There's a few other things I could have shared, but I think time's running past, so we'll leave it there and over to you.
Thank you, Dave. Thanks for a brilliant talk. I really appreciated that. I put out a call for questions, but I'm gonna lead with a few if I may. I'm really interested in first steps and trying to envisage what healthcare professionals will be doing right now at this point in terms of managing the COVID-19, the fallout from COVID-19 in terms of mental health. Whether you could just talk through some of the first steps that will be at this stage currently being processed.
Well, going back to what I was saying earlier on, I think clearly the people who you would be looking to as being most at risk are those who have had the most direct experiences. And I think that's an important point to make, because over the years there have been people commenting on Northern Ireland saying that the total population is traumatised. And whilst it's true to say the total population has been in some way or other affected by the violence in the Troubles, it is untrue to say that the total population is traumatised, and most people are actually okay, and in spite of any experiences they might have had. So you're looking for those most at risk, and then finding a way of trying to case find within that. And one of the arguments that we could make is for screening of people, for example, who have been through intensive care, the screening of staff who have been working on intensive care or in accident emergency departments or indeed in other departments. The screening of other high-risk groups, for example, that we often overlook, like, for example, undertakers or clergy who've had to minister, other faith leaders who've had to minister in a situation where families couldn't be involved, etc. So you're looking for those high-risk groups, and at the same time opening up wider avenues of access to services to the wider public. And that will be through your conventional services like general practitioners, through your voluntary organisations, and indeed through your mental health services. In relation to mental health services, they will be looking out, I would expect, for people who have chronic and severe mental health problems, just in case the sense of general crisis within the community has stimulated any adverse impact on their part. And obviously looking out for people who may be at risk of suicide in that regard.
Okay, thanks, David. And on the opposite side of first steps, the aftermath. In terms of predicting how long the aftermath will last, how would someone quantify that? How would you look at the long-term effects of COVID-19 on mental health in society?
Well, I think that you saw from that chart that it takes on average 22 years for people to seek help with anxiety and, we might say, trauma-related disorders. Thankfully, people with mood disorders come through very quickly, which is good. Now, when I say on average, that means within 22 years, only half of those with problems have sought help, and there's another half yet to seek help. So I think the key here is that we will need to put in place special measures to deal with the immediate mental health difficulties, additional mental health difficulties that arise. But I think another task is to actually equip our mainstream, ordinary, everyday mental health services to be in a position to carry the work forward in the long term. That's effectively what happened with our first trauma team in Omagh, that the trauma team took the initial wave of referrals that came in. But by the time the team closed 2.5 years later, general practitioners, local volunteers organisations, the wider mental health services were beginning to pick up the referrals, had indeed developed the know-how and skills to spot needs, to refer people appropriately, and indeed in some cases to deliver trauma-related services. So we're trying to skill up a total system here. And I suppose one of the objectives we should set ourselves out of all of this is that, in 5 years, 10 years time, we will have even a better mental health service. And that will be backed up by good social policies that address those conditions and disadvantages that are associated with poor mental health.
Thank you, David. Okay, I've got a couple of questions here. So, how are communities transformed as a whole, so on a communal level, by these traumatic experiences?
Yes, I think that it can go either way. I look back on, I was involved in not just the response to the Omagh bombing, but also to the Enniskillen bombing. Indeed, it's my hometown, as it were, and so knew it personally as well as professionally. And I look back on Enniskillen, and in a short space of time, people began to feel very proud of their town, of their community, of how it responded, and indeed it orientated many people towards very positive choices in their own personal lives, in their relationships with other people, and indeed it'd be fair to say that it increased cohesiveness. Addressed underlying things like sectarianism to some extent within our community, and many initiatives that are still in place today grew out of that tragedy. Same thing happened to some degree in Omagh as well, and that potential is there. But it's also true to say that these events pose a considerable risk to communities, and that if you don't have the community leadership, civic leadership, political leadership to orientate and take people in the right direction, then positive outcomes at a community level aren't necessarily guaranteed.
Okay, thanks, David. So I've got another one here. What interventions are most helpful, stroke important, during periods when the traumatic event is ongoing, so without an end in sight, when you're probably deep within the COVID-19 or the bombing?
Yes, I think this is an important point because from a therapist's point of view, you don't want to be offering services that are irrelevant to the person who is seeking help or at the time. So this is the key to this is the therapeutic relationship and the therapist's ability to understand and judge the right level of intervention that is required at that particular point. So if you're, for example, an emergency member of staff working on a COVID-19 ward and witnessing on a daily basis the stresses and strains of that experience, and indeed sitting with people who are dying and who can't have their relatives with them, that's highly stressful. But it would be wrong to embark upon a post-trauma therapeutic protocol-driven intervention at that point. And the key is to making sure the person feels supported, that they have immediate access to emotional support, and that they are given the kind of the guidance and nudges that are needed to help them to live with some degree of resilience through this experience. To take a break if necessary, although that's not always a good idea, it may seem intuitive, but putting people off work may not be the best thing. However, sending somebody home to have a sleep is a good idea because often exhaustion is the problem. The danger is that people get to rely on alcohol or other substances to try and get them through this period, or disconnect themselves from family, and indeed may forcibly have been disconnected because they had to isolate themselves from their families. And that's not necessarily good. Social isolation and the use of synthetic substances to try and cope is not a good idea.
Okay, thanks, David. So I've got one final question, and I was really taken with your slide on the importance of creativity in terms of articulating the experiences and trauma. Is there anything from your experience you can suggest that, particularly those who are unaffected or haven't experienced the trauma, they should be doing at this time in terms of in a supportive or helping role? Yes,
well, I think we tend to think of things like funerals as being, the formula, the ritual of the rite of passage of a funeral as having always been there. But that's not the case, and in fact, they've evolved over time and continue to evolve. And I think the important thing is that both at a personal level, a family level, neighbourhood, at a church or faith community level, there's nothing wrong with creating new rituals but the important thing is that those rituals and rites of passage are meaningful and authentic to the people involved. There's no point in creating something that doesn't connect emotionally with the person who's bereaved, for example. So I think that I often find that people like hospital chaplains, people, religious leaders, can be very good at bringing the right words and the right things to do into these situations. Undertakers understand a lot of this thing very well, and I think that they can play a meaningful contribution. For those who have where death and loss hasn't been involved, I think that there are rituals and practices that we can engage with that become meaningful to us, and it's about, for example, acknowledging the goodness in people, being thankful, being generous in our own relationship with others, and being attentive to the needs of others. I think can all be very important part of how we live our lives in these kind of situations.
Okay, thanks, David. I think this is a good moment to wrap up this armchair event and thank everyone for attending. But in particular, David, thank you for giving up your time to participate in this excellent armchair event and for the presentation